So it's a very vast topic. Basically, we can speak individual drug in a single lecture. In fact, so I'll give a brief overview of all the drugs, which is the common drugs, and then later on we can do the discussion, interaction, and your doubt about any drugs and special side effects about the cardiovascular medications. Very busy slide. So I have divided the slides based on the different drug groups. So this is the renin-angiotensin system medications, which is which basically acts on the renin-angiotensin system and the aldosterone system. So we all know that these are the captopril, enalapril, lisinopril, and lots of other things. Directly acting angiotensin receptor blockers, losartan, valsartan, and the aldosterone antagonists, that is spironolactone and the eplerenone. Okay, so basically ACE inhibitors and the ARBs. The main side effect of the ACE inhibitor is the cough, which we usually in our clinical practice, which we encounter around 10 to 30% of the patients, and that is because of the angioedema and other very serious side effects sometimes which happen with the ACE inhibitor is the angioedema. And that happens because of the increased bradykinin. It is an endogenous vasodilator. Basically, the breakdown pathway of the bradykinin is also inhibited by the this molecule, and that's the reason for this kind of serious side effects. Coughing is usually subsides when we switch over from the ACE inhibitor to the ARB in majority of the patients, and doesn't require any specific intervention or treatment for that. Another side effect is that worsening of the renal function and hyperkalemia, which is very, very common, especially in the initial period. And that's the reason once we start the ACE inhibitor or the ARB, it is the must to do the RFT in 7 to 14 days of the time period to look for the hyperkalemia and worsening of the renal function. So this is very, very common, and this side effect is even common with the ARB also. ARB anyway doesn't cause the angioedema and the cough, which is because of its directly acting effect on the receptor itself. So these are the common side effects of the ACE inhibitor and the ARB. Both this class of molecules are contraindicated in the pregnancy because of the fetal renal toxicity. So in the patient with the pregnancy-induced hypertension or the female patients who are already taking on this molecule, we have to encourage to stop these medications prior for the pregnancy. Renal artery bilateral stenosis. This is very, very important. Now this both the molecule affects on the efferent arteriole, and that causes the dilatation of the EA, and that will reduce the GFR. So if the patient having bilateral renal artery stenosis, the constriction of the efferent arteriole is very, very important to maintain the GFR and to maintain the renal function. And that's why giving this molecule to this subset of the patient can create a hazardous, and then can create a major problem. And that's why it should be the contraindicated for bilateral renal artery stenosis. Another important molecule is aldosterone antagonist. These are the spironolactone, and the newer molecule is the eplerenone. Aliskiren is no longer used in the clinical practice because of the lots of side effects. It was initially introduced as an antihypertensive medications, but it is not available in India as well. So spironolactone and eplerenone, again the major side effect is hyperkalemia, gynecomastia, which is common with the spironolactone but not with the eplerenone. Again, worsening of the renal function, rare case renal stone because of the calciuric effect of this molecule, hyperchloremic and metabolic acidosis. These are the very rare side effects, but the major side effect which we need to look for is the hyperkalemia and gynecomastia. Gynecomastia is very common with the spironolactone. Again, contraindication when the patient already taking ACE inhibitor or ARB, we need to be vigilant to look for the renal function and hyperkalemia. And in liver disease, because of the excretion of this molecule through the liver metabolism, it should be cautiously used in the patient with the liver dysfunction. Another subset is the beta blocker and the alpha blockers and the combined blockers with the central acting medications. So beta blocker, we know these are the selective beta blockers, metoprolol, nadolol, propranolol, and especially if you see metoprolol is selective because it is acting only on the beta 1. While the propranolol, it is acting on both beta 1 and beta 2, is not selective. So there are few of them which are selective, few of them which are not selective. The side effects which is mentioned here is the in general side effects of all the class of beta blockers, especially derangement of the lipid profile. that will be increase in the triglyceride and the LDL, which is not that much a profound effect clinically, because most of the time these molecules are prescribed in the patient with the coronary artery disease and the heart failure patient. So anyway, these patients are taking statin and lipid lowering medication. So this side effect is not that much profounding, especially in the heart cardiac patients. Bronchospastic disease, especially with the reactive airway disease, Bradycardia and Av Block. This is very, very important because both all these molecules are creating the increase in the Av delay, and that's why it creates the Av Block. If the patient already having some sort of Av conduction delay, that can be aggravated by this molecule. Acute cardiac decompensation in some of the molecules can create the acute precipitation of the decompensation of the heart failure. So we have to introduce this molecule in the heart failure patients gradually, and we have to titrate the dose accordingly. Withdrawal syndrome, when we stop this molecule, there will be the possibility of the upregulation of the beta-1 receptors, and that can create the reflex tachycardia, or even sometimes if the patient is already on the heart, patient already having the heart failure, that can aggravate the heart failure and the acute decompensation. Fatigue, cold hands, this is all because of its peripheral arterial effect. Central actions, side effects like sedation, depression, vivid dreams sometimes. Impotence is again a common side effect with the beta blockers, and abrupt discontinuation can lead to myocardial ischemia, as I mentioned you, because of the up titration of the beta-1 receptors. Contraindication, this is now more contraindication with the routinely available beta blockers, type 1 diabetes, because it masks the hypoglycemic tachycardia. So basically it masks the hypoglycemic episodes effectively. So that's the reason for the contraindication that was with the previous generation beta blockers. Nowadays with the newer generation, it is no more contraindicated in that situation. Asthma, especially the severe asthma and the severe COPD. So basically all the beta blockers, especially the selective beta blockers, are safe in all sort of COPD patients, except the patient having severe reactive asthma. This kind of molecule we should avoid. Otherwise, in COPD patients, we can safely give this molecule whenever it is required, whenever it is indicated. Advanced heart block, peripheral vascular disease, and there is one variant of the angina, that is Prince metal angina, that is basically vasospastic angina, which happens in some sort of patients, and in those patients beta blockers should be avoided. Alpha 1 blockers, again doxazocin, prazosin, terazosin, mixed alpha and beta blockers, that is carvedilol and labetalol. Especially it has been used for the some sort of hypertensive emergencies like pheochromocytoma. That is the main indication for that. Even carvedilol is used for the decompensated heart failure. And centrally acting alpha 2 agonist, these are again the powerful antihypertensive molecules like alpha methyl dopa, clonidine and reserpine. The major side effect is again the CNS, that is depression, sometimes suicidal tendency with the reserpine is very common, and that should be always evaluated while giving this kind of molecules. Next subset is the peripheral vasodilators. These are the minoxidil and hydralazine. Especially with the minoxidil, that can create the rebound hypertension. That is sometimes called as pseudo hypertension in the literature. And when we stop, or when the patient miss the 1 or 2 pills of the minoxidil, that those patients having rebound severe hypertension. So it is very, very important to give this molecule with proper education to the patient to avoid this kind of problems. Lupus-like syndrome that can happen with the minoxidil in some patients. Angina, tachycardia, headache, nausea, flushing, sweating, all these symptoms is because of the peripheral vasodilation, because these are the powerful vasodilators. These are the potassium channel openers. So these are the side effect is very common with this molecule, and this is a powerful antihypertensive also. Another subset is nitrate. These are the all nitrates which is available, and majority of the time this nitrate side effect is the orthostatic hypotension because of the venodilatation and reduce venous return and reduce cardiac output. Most important thing regarding the nitrates, which I would like to highlight, is that don't give this molecule with the erectile dysfunction drugs, especially sildenafil, tadalafil kind of medications, because combination of these drugs can create severe hypotension and sometimes sudden cardiac death. So many a time we can see the patient having already on the nitrates. We should always restrain to give the phosphodiesterase inhibitors for the erectile dysfunction, and this is very, very important. Next subset is sodium nitroprusside, which has been given for the hypertensive emergencies. Cyanide intoxication, that is common or not very common, but one of the major side effects or important complication which we need to look for when we give the sodium IV sodium nitroprusside. Hypotension and hypothyroidism, which are the rare. Hypotension is common, but hypothyroidism is very, very rare. Neziritide, this is a calcium channel, is inotropic increased cyclic GMP which relax the arteries and veins, and that has been used in sometimes in some of the patients with the heart failure, and that is synthetic actually brain natriuretic peptide, and major side effect of this molecule is to look for the hypokalemia. Next subset is the calcium channel blockers. These are the subset, these are the molecules in this category. Major side effect again, AV block, acute heart failure, constipation, edema, nausea and flushing. Concomitant use with the beta blocker should be avoided because it can create the heart block and severe bradycardia. Another one is digoxin, which was used very commonly in the heart failure patients, but nowadays very few specific indications are there for the digoxin, and it is having lots of side effects when we give it in the high dose. So like AV blockage, ventricular tachycardia, lots of GI side effects, CNS side effects, ECG abnormalities in that. So all these abnormalities can happen with the digoxin. Especially we should be very, very careful when we give digoxin with the quinidine, codaron, verapamil and loop diuretics, because of the interaction of this digoxin with this molecule can create the increased toxicity of the digoxin. And another thing is hypokalemia, which we need to look for, because hypokalemia can aggravate the toxicity of the digoxin. And the last one, thiazide and loop diuretics. So basically, this kind of diuretics can create the electrolyte imbalance. That is very, very common side effect. That is hypokalemia, and especially when we use the other molecule like digitalis, which this molecule can aggravate the toxicity of the digitalis because of the hypokalemia. So we need to be very, very vigilant while giving this kind of molecules. Hyperuricemia can happen because of the uric acid retention by this molecule. Some of the molecules, especially the thiazide one. And many times there will be the increased increased tendency for the calcium stone because of the increased calcium excretion by the diuretic, especially the thiazide kind of diuretic. So these are the common side effects of the major cardiovascular medications. Any questions or any discussion? I think at the end of session.